Welcome to Sleep Medicine and Physical Therapy Part 1. Basic Concepts. Sleep. Definition. Concept. New era for physical therapy. Sleep is often characterized by the reversible reduction in consciousness, an increase in arousal threshold, behavioral quiescence, closed eyes, and a recumbent body posture. Sleep is an essential physiological motion for the maintenance of homeostasis of our organism, being a state of intense brain activity. Sleep was considered a passive state until the discovery of rapid eye movements. Sleep in 1951, today called the R stage. At that time, and prior to that time, no distinction was seen between sleep and other states of quiescence, such as coma, intoxication, anesthesia, and hibernation. Sleep represents an essential element for health and well-being, including cognitive performance, physiological processes, emotional regulation, physical development, and quality of life. Sleep remains a scientific enigma, and we do not know sleep functions precisely. We do know that we cannot survive without it. Many scientific investigations on the function of sleep have proposed a variety of theories. Sleep serves an immune function, reduces caloric usage, restores brain energy stores, and a glymphatic function, restores waking-induced performance degradation, and may also serve a neuronal glial connectivity function. In addition, we have many investigations on this active process, providing daily restoration due to the production of fundamental anabolic hormones involved in cellular growth and regeneration, such as growth hormone, testosterone, and prolactin. Theories as to the function of sleep have naturally focused on the brain. The synaptic homeostasis theory, the brain energetic restoration theory, the memory consolidation theory, and the macromolecular biosynthesis theory have all cited a central emphasis on the significance of sleep for the brain. Unforgettable, there is a declaration of sleep being a product of the brain, by the brain, and for the brain. The effects of sleep and sleep deprivation on the body are hard to ignore in humans. There are well-characterized physiological and behavioral changes known to impact the pathophysiology of several diseases such as metabolic dysfunction, hypertension, stroke, diabetes, neurocognitive diseases, heart diseases, musculoskeletal function, and altered immune function. Taken together, these comorbidities increase the morbid mortality associated with sleep and sleep deprivation. Given this context, it is reasonable to suspect that sleep state impacts a broad array of peripheral tissues in addition to the brain. In this sense, transcriptional effects of sleep outspread further than the brain to include peripheral tissues. The propensity to sleep is determined by two processes, the circadian and the homeostatic processes. The two intertwined process model postulates that the homeostatic process increases during waking and decreases during sleep and interacts with a circadian process that is not directly dependent on sleep and waking. In the circadian process exists a time mechanism of the body where hormones are produced and released, for example, glucocorticoids, melatonin, cortisol, influencing endocrine function. There are either fluctuations of core temperature, performance, muscle strength, rhythms in behavioral processes, for example, locomotor activity and feeding. In humans, the circadian rhythm is about 24 hours, and for our biological clocks to be effective, they must be accurately keeping time and adjusted to environmental signals, for example, night and dark. Feeding and fasting, activity and rest. In the homeostatic process, sleep pressure is increased as longer as we are awake, and consequently there is an increase in adenosine, an endogenous hormone that promotes sleep. Adenosine also dissipates during sleep and thus induces wakefulness for the next day, together with an orchestra of other hormones. That is, sleep is also regulated by the accumulation of its debt. The more the wakefulness, the more the need to sleep accumulates, until the moment when this accumulation becomes unbearable and it is necessary to sleep. We sleep when these two processes are in tune, the circadian process indicating that it is time to sleep, and the homeostatic process indicating that there is an accumulation of need for sufficient sleep. The interaction of both processes determines the time of sleeping and waking up. The desynchrony of these processes can lead to many diseases. The identification and classification of sleep stages are made by polysomnography examination. In PSG, the characteristics of each of the stages are well defined and measured through the EEG waves according to their frequency and amplitude. Sleep has two separate stages defined based on an assemblage of physiological parameters: the R stage and the non-REM stage. The non-REM stage is further subdivided into stage 1 and 1, stage 2 and 2, and stage 3 and 3 sleep. A sleep cycle is composed of consecutive alternations between the non-REM and R stage, and lasts about 70 to 110 minutes each. Humans experience about 4 to 6 sleep cycles per night, with different proportions of each stage throughout the night, and vary according to age, sex, exposure to daylight, diseases, etc. In normal individuals, non-REM sleep predominates in the first half of the night, while REM sleep is more frequent in the second half of the night. The schematic representation of the sleep architecture, sleep structure, and sleep pattern can be seen in polysomnographic examination in the hypnogram, a graph that characterizes the sleep stages as a function of time. There exists a protocol defined by the ASM for sleep scoring. Normal sleep pattern begins at the N1 of non-REM state, which constitutes the transition from wakefulness to sleep and is predominantly characterized by the transition from alpha rhythm to theta rhythm from 4 to 7.5 Hz. From the time an individual goes to bed to sleep and the time he or she effectively starts to sleep is called sleep latency. During stage N1 sleep, the heart rate decreases and the eyes exhibit lenient movement. N1 sleep stage represents typical graphic elements in EEG, such as the vertex waves. The vertex waves progress through deeper non-REM stages N1, N2, and N3 before the first episode of REM sleep, which occurs about 80 to 100 minutes after N1. Here, the time from the beginning of sleep to the first REM sleep stage in the cycle is called REM sleep latency. Back to sleep pattern, most of the night's sleep occurs in N2, characterized by slow waves, that is, theta waves with decreased frequency, low amplitude, and graphic elements such as sleep spindles and K complexes, related to sleep maintenance. Sleep spindles are bursts of neural oscillatory activity that are generated by the interplay of the thalamic reticular nucleus and other thalamic nuclei in a frequency range of 11 to 16 Hz, with a duration of 0.5 to 1.5 seconds. Sleep spindles are an EEG hallmark of non-REM sleep and are believed to mediate many sleep-related functions, from memory consolidation to cortical development. K complexes have the functions of suppressing cortical arousal in the response to stimuli that the sleeping brain evaluates, not to signal danger, and supporting sleep-based memory consolidation. At the N2 sleep stage, there are slow or absent eye movement and moderate muscle tone. The N3 stage of non-REM sleep is composed of high amplitude waves called delta waves, which makes it the deepest sleep, with a higher threshold for awakening and more intense brain synchronization seen in the EEG. Night terrors and sleepwalking can occur during N3 sleep. In non-REM sleep, there is a regular decrease in ventilation, effectiveness of proprioceptive reflexes and chemoreceptors is maintained, and intercostal muscles are active. There are also maintenance of muscle tone of the upper airways, with a decrease in heart rate and regular decrease in blood pressure and cardiac output. Therefore, the EEG pattern in non-REM sleep is commonly described as synchronous, with such characteristic waveforms as sleep spindles, K complexes, and high-voltage slow waves. Finally, REM sleep is characterized by EEG activation, muscle atonia, and episodic bursts of rapid eye movements, presenting with a mixed frequency of fast brain waves with theta and alpha waves, desynchronized, indicating very intense brain activity with or without the presence of sawtooth waves, triangular 2 to 6 Hz with greater amplitude in central regions. In the REM sleep stage, there is muscle hypotonia. As the brain blocks motor neurons, consequently, the body does not act the dreamed orders or waxes them. Brain activity is intense, similar, or even higher to the state of awakeness. REM sleep stage was once known as paradoxical sleep, exactly by the paradox of being very intense activity of the mind and extreme relaxation of muscles. In REM sleep, ventilation is variable and quick, proprioceptive reflexes and chemoreceptors are abolished, intercostal muscles are inactive, hypotonia of the upper airway muscles is observed, heart rate becomes faster, irregular oscillations of blood pressure and cardiac output occurs. Therefore, a quick definition of REM sleep is an activated brain in a paralyzed body. For the first sleep cycle, sleep does not start in N1 and goes through N3 and N2 and REM sleep stages. Individuals who are deprived of sleep, for example, may initiate sleep in REM sleep stage, a condition called sleep rebound, a strategy to our organism to compensate for some functions of the body going directly to the needed sleep stage. Sleep deprivation and issues regarding sleep may in the long term lead to sleep disorders comorbid with other diseases, with a negative impact on health and functioning. In this sense, PTs are in an ideal position to promote health and wellness, prescribing physical activity and exercise, educating patients and clients to adopt a regular physical activity regimen, performing hands-on interventions consistent with the biopsychosocial paradigm, and educating patients and clients about sleep. PTs are in the ideal position due to the nature of PT's scope of practice, having constant and persistent access to their patients and clients. As the profession changes and improves over time, based on scientific developments, PT's practice in contemporary times include sleep health. The WHO has an international classification of occupational professions, essentially reflecting the distinction of subgroups of health workforce according to assumed differences in skill level and skill specialization required to fulfill the tasks and duties of jobs. PTs are under the classification of health professionals focused on study, advised on, and provide preventive, curative, rehabilitative, and promotional health services based on an extensive body of theoretical and factual knowledge in diagnosis and treatment of disease, health difficulties, and conditions. PTs assess, plan, and implement rehabilitation programs that improve or restore human motor functions, maximize movement ability, relieve pain syndromes, and treat or prevent physical challenges associated with injuries, diseases, and other impairments. They apply a broad range of physical therapies and techniques such as movement, ultrasound, heating, laser, and other techniques. They may develop and implement programs for screening and prevention of common physical ailments and disorders. On the other hand, for the patient, many diseases or conditions may ameliorate if sleep is properly assessed and treated. as sleep has an imperative function in most of our body systems, such as modulating pain and mood disorders, memory and learning, cognitive function, immune function, cardiovascular health, and more. So, adequate sleep with regard to amount and quality can aid within rehabilitation and physical therapy. On the other hand, PTs can perceive sleep issues in their patients, access and refer to physician and other health professionals, and treat the disturbance along with the physician and other healthcare providers in an interdisciplinary manner. Therefore, PTs can treat sleep disturbances by a variety of techniques, methods, and resources.